Hi, my name is Martin Köring. I'm a managing editor and also global editorial lead for the healthcare sector at the Economist Intelligence Unit's thought leadership practice. Welcome to today's live global webinar. We're looking at action on stroke, policy approaches to prevention. This is a really important topic. We've just released a new report, infographic and study on this important topic. Up to 80% of strokes are preventable. We know that, and we have actually every 2 seconds in the world there is a stroke, and every 5 seconds someone dies of the effects of stroke. But we know that stroke is preventable, so it's really important to look at what kind of approaches there are and what kind of policy can be put in practice to prevent stroke. Today we have a distinguished panel of experts that the Economist Events has put together. This webinar is, as I said, it's a global webinar with a global audience. It's sponsored by the Pfizer Ems Alliance. And we have this panel of 5 experts, and I'd just like to ask each of the panelists to introduce themselves briefly.
Sure. Thanks, Martin. So my name is Massam Hussain. I'm Vice President and co-lead for the alliance between Bristol Myers Squibb and Pfizer. One of the areas of interest for the alliance is prevention of stroke by increasing the detection and diagnosis of atrial fibrillation. I'm a medical doctor by trade with a background in neurosurgery and clinical epidemiology.
Great, thanks.
Hello, my name is Valeria Caso. I'm a stroke neurologist from Perugia, Italy, and I'm the current president of the ESO, which is the European Stroke Organization, the leading stroke organization in Europe. And we, as an organization, we do research on primary prevention of stroke, the acute pathway, secondary prevention, life after stroke, and rehabilitation.
Great, thanks.
Hello, I'm Markus Wagner. I'm working for the German Stroke Foundation for 18 years now. And I'm the Vice President of SAFE, which is the European Patient Organization. And I'm a human biologist and also have a degree in public health, so I'm very interested in the topic for many, many years.
Great, thanks.
I'm Barbara Casadei. I'm a British Heart Foundation Professor of Cardiovascular Medicine in Oxford, in the UK. And I am the President-elect of the European Society of Cardiology. My research interest is atrial fibrillation, and as a Vice President of the Society, I started the Council on Stroke to increase the collaboration between neurologists and cardiologists on this disease.
Sounds good.
My name is Morten Rosenqvist. I'm Professor of Cardiology at the Karolinska Institute in Stockholm. I've devoted my research during the last 20 years to atrial fibrillation, especially with emphasis on screening for atrial fibrillation as a way to prevent stroke.
Great, thank you very much. As you can see, we have an expert panel here today. The webinar will last about 45 minutes, but we really encourage you to also post your questions. This is a live webinar, so you have an opportunity to post your questions, and we try to bring your questions into the debate as much as possible. So feel free to take part in this webinar. There are several topics we really want to go through, and we don't really have much time. But let's start with the healthcare infrastructure that is in place, the system that is in place to really look at stroke and how to prevent stroke. So in our study, which included 20 countries, we looked at how healthcare systems can play this crucial role in managing at-risk populations, to really look at educating and motivating both the general population but also healthcare professionals to really look at stroke risk factors, which are very, very much known, and also making sure that patients look after their own health. And we looked at the countries, 20 countries, and actually they do quite well in this category. I mean, on the surface level, they're actually quite good at putting in place a healthcare system and infrastructure to look at stroke prevention. For example, they all exceed the recommendations by the World Health Organization in terms of having the number of medical professionals in place, like nurses, physicians, midwives, and so on. But we still see issues with stroke prevention. As I mentioned earlier, the statistics show that the disease burden for stroke is rising. So to what extent are medical professionals really properly trained to identify and also to treat stroke risks? And this question I would like to start with the cardiologists that we have here in the panel. So potentially, Martin, would you like to start?
I think that we are trained as cardiologists and primary care physicians to check for blood pressure, for example, to see that if patients have hypertension. But we are not as well trained for detecting atrial fibrillation. we are not so far connecting atrial fibrillation with the risk factors that are identified, and I think we have to work much more forceful on this.
Mm-hmm. And Barbara, what would you say about?
Yes, I mean, I would agree that that is the case, although there are, it depends what kind of screening we do for atrial fibrillation, because we don't always have the evidence that anticoagulating patients at high risk of stroke that have maybe very infrequent and short episodes of atrial fibrillation would actually be beneficial. So we're still needing the evidence. I think it's also important to train the patients to be aware of these risk factors. It's not just a one-way a message that can be conveyed. It has to come from both sides.
Do you agree, Valerie?
Yes, I think that after the age, for example, of 40, we need all start to measure our pressure. After 65, to control the pulse by yourself, or it's also written in your very well written in the European Society of Cardiology guideline that the doctor has to check only for the pulse, just sometimes to check if there is a atrial fibrillation arrhythmia. So I think it's very important, because we have a five-fold higher risk of having a stroke if there is atrial fibrillation.
And do you think that medical professionals are trained properly?
Unfortunately, when we are talking here together, we are all expert and everything seems to very fixed up and everything we all agree. But then you go to the primary care physician and they tell you, oh, I'm overloaded by a lot of work, and they are not trained enough to understand that it's a priority. Cardiac disease is #1 killer in the world, and stroke is is the #1 cause for disability. But they are not trained enough to understand this.
Okay. And from the patient perspective, Marcus, do you think medical professionals are properly trained and motivated and educated?
Well, I think the training mostly is very good. As Valeria mentioned, sometimes they don't have the time, sometimes they don't have a reimbursement system in place. And on the other hand, to communicate to the patients the need, what is behind the screening, and also what can be done. For instance, if you tell a patient, well, you have a risk factor, out of the blue, he says, well, what can I do now? Well, yes, maybe I have a pill for you. But it also depends on the lifestyle. So I think it's not only the job of the medical doctors to train people when it comes to lifestyle. This should be an activity for many healthcare people. And also, I think as there is not much time for communication, patients don't understand really the consequences. And so therefore many patients tend to say, well, when something happened, nobody told me. And I think that's not true. They have been told, but the perception is difficult.
Okay. And from the private sector perspective, from the pharma perspective, what is your view on the training and education of medical professionals for stroke prevention?
Yeah, well, you know, around 75% of people over the age of 65 are not screened, right? And I think there are a number of barriers, including, you know, training, education, awareness. I would say the other barriers are healthcare infrastructure, healthcare resources. It could be the right technology. It could be the economics of screening. In the private sector, I think we can do quite a lot to overcome some of these barriers. In fact, the Alliance is partnering with a number of stakeholders to run pilots and activities in a number of countries, including the United States, Germany, Australia, Canada, and we're taking the opportunity to incorporate some of these technologies to see how we can incorporate screening into routine clinical practice and do it in a way that is economically feasible and efficient.
And the topic of screening comes up a lot, and we'll discuss it in more detail. But I mean, you also mentioned the importance of having patients educated and aware. So maybe let's discuss more in terms of what you think should happen to really improve stroke awareness, because we know that the risk factors for stroke and also the methods to manage stroke are actually quite well understood. And we looked at, in our study, we looked at 20 countries from around the world, developing and developed countries, and there is actually awareness of stroke risk factors. And but at the population level, it is not big enough. And obviously, we see a lot of areas like atrial fibrillation that you mentioned, where there is very little awareness. Even in terms of high blood pressure, there isn't enough awareness. So how can awareness of stroke risk factors really be improved at the population level?
I think that we should really share what is written in the guideline. What is the most difficult part of when you write a guideline? The guideline, we are sitting together, wonderful experts, high level of evidence, but then you have to go to the implementation. And the implementation to the population is the most difficult step. So we really have to say, look, it's very, very easy not to get a stroke, because all your risk factors are modifiable, and you don't have to use a lot of costs, or it costs you some time to control, just to control yourself, or go sometime to the general physician and check your pulse. That's it. But I think the way how from here to reach to the population, we have to improve ourselves as doctor in our communication, but I think we are starting today, for example.
What do you think policymakers can do, maybe from the patient perspective, at the population level? What can policymakers do to improve awareness?
Thank you. I think it's a very old question, what we do, high-risk approach or population approach, and we have to balance these approaches. So from my point of view, I think we should have to start quite early. And it's the old slogan, make the healthier choice the easier choice, is still true. Yeah. And on the other hand, starting quite early with education, without fear-mongering. Children don't want to hear about stroke, but maybe we want to hear about how they should react if grandfather or grandmother has symptoms. So this is something that is quite important. And this has to start quite early, but on the other hand, we have to have systems in place that these messages get through. So on the other hand, we have a lot of information available, and we have a very strong message. 70 or 80% of all strokes can be stopped or will never happen. So this is something we have to translate, and I think we have to be more creative with our messages.
And you mentioned it. It's actually it is actually pretty, possible to prevent a stroke. It's highly, desirable that everyone knows how to prevent it. That there are lots of things that people can do to prevent stroke, but also in terms of recognizing the symptoms when they see it, or family members. But what is really done to improve this awareness for people, not just at the population level, but also for people to know what the stroke risk factors are?
In my view, we should probably stop having the classical paternalistic approach by which the doctors tell the patients what they should be doing. And I think involving the patients in the decision is key. So, for instance, the European Society of Cardiology has decided to produce a digest of the guidelines directed exclusively to the patients in a way with a language that is direct and easy and clear to understand, and to involve the patients in the task force of the guidelines. So that we have that involvement from the very base of the decision making. And I think that is essential, because at the moment, particularly the new generations, are really not prepared to be told what to do with their life or their lifestyle. And I think the awareness of this is essential.
This is a very, very good point. And you see, for example, that the escalation of stroke in the baby boomers, which were born in the 60s, 70s, they are increasing, and the oldest are decreasing because they have been well prepared. But the generation after, there's a huge increase of the risk factors, and they don't care about it. And they have the skills now with internet, and if you as society involve them, I think this is really, really excellent.
I think that everybody who has a friend or a relative who has sustained a stroke will be quite aware of how terrible this disease is. And I think we should use that because we have been able to educate people about the seriousness of chest pain or myocardial infarction. And I think you really have to see what the consequences of a stroke is. And I think that picture is going to make people very much aware of how serious this is.
Yes, stroke is, it's, you know, even if you don't have deficits, sometimes motor deficit, you can have cognitive deficits. And the best way to, the best stroke is the stroke that you will never have. So the prevented stroke.
Absolutely.
That's right. I also think that we have to teach other specialists, not only cardiologists, about checking the pulse. We have to teach surgeons and orthopedics how important it is to do it, not only measure the blood pressure.
I mean, you mentioned already that it's so important to have have screening. I mean, having proper screening in place, and we did in our study. We analyzed screening for risk factors, and most of the 20 countries we included in our study, they have included and adopted national evidence guidelines. You mentioned the clinical guidelines, so national evidence-based guidelines are in place in many of those countries. But still, screening is not really happening. So it's not really happening in clinical practice for things like high blood pressure and also for atrial fibrillation. And it's not really regularly performed, although cardiologists and even GPs that are aware of the risk factors, even the general population, and if you have a family member that has been affected, they are aware of it. But how can we improve screening? Why do you think screening is still such an issue, although we know how beneficial it can be? And how can we really improve screening policies?
I think we should learn from the best, who did already a good job. Now, as a woman, I can tell you that we are really aware about the risk of having breast cancer. So, but if you look at what I can have in the lifetime, I have much higher risk to have a stroke compared to the risk to have a breast cancer. So we have a little bit to focus what are the risk factors for the likelihood of the disease that you can have in your life. It does not mean that we have to stop to look for breast cancer. This is absolutely not my message. But to say you have overall, let's say, 20% lifetime risk to have a stroke, and this has to be shared. And with very cost-effective and easy tools, you can prevent such an expensive disease.
I like to sort of play the devil advocates here in the favor of physicians. So say, for instance, why isn't the screening always done? There is not only atrial fibrillation, but the risk of stroke a priori that determines what you can do to these patients. Now, you could argue that we could move to a model that is similar to the lipid model, and that is that we now lower the lipid independent of the lipid level, depending on the risk of the patients. And so now there are emerging data that looks that small doses of anticoagulants can prevent ischemic stroke very effectively in all patients. So you could argue that you could identify patients at high risk and whether they have atrial fibrillation or sometimes a bit of atrial fibrillation, or maybe it doesn't matter. And it's the risk that determines the intervention rather than whether you're able to catch those 5 minutes of atrial fibrillation.
So if that's possible, why is it not happening? I mean, you're saying it is possible, but we have actually surveyed medical professionals, and they're just not doing it consistently. So what's the barrier?
Well, I mean, the evidence for this particular scenario that I've just outlined, it's a trial that has been presented last September. So I think that it will come up, but the evidence is starting to emerge, and there are other studies that indicate, for instance, no temporal relationship between short episodes of atrial fibrillation and stroke. And so the causality of the two is in question. So it could be a biomarker, atrial fibrillation, of a status of high cardiovascular risk. And as such, one could tackle directly that.
And you believe that that would then spur an increase in screening once that cause a link?
Well, the screening may become irrelevant at that point.
So to start immediately to start the
You are targeting the risk, and you are not targeting the detection of atrial fibrillation, which you know it may be there, but you need very many months of screening in order to catch those infrequent short episodes.
And what about high blood pressure?
No, high blood pressure is an easy one.
80% of strokes.
I think if we stick to the guidelines that we have today, every patient 75 years old who has atrial fibrillation detected or on an ECG has a very high, strong indication for anticoagulation treatment. In the future, we might say that we should start everybody who is 75 on anticoagulation, but today we have a very strong indication for this. And my suggestion is that every person coming to the primary care center, whatever the reason is, should have his pulse checked. And if we can verify that there is an ECG showing atrial fibrillation, this patient should be offered anticoagulation treatment. Checking the pulse doesn't have to be done by a physician. It can be done by almost anyone working on the primary care center. So I think that would be a very easy, inexpensive way to screen for these patients. We're not talking now about patients with short episodes where there is some question. We're talking about patients having what we call a permanent atrial fibrillation. And we will detect about 1.5 of all patients at maybe even more if they are 70 to 75 years old. Easy, inexpensive.
But what I always, when I talk with my patients, say, okay, I give you the drug, but you now have to lose weight, you have to stop to smoke, and please start some physical activity, because it's not giving only the drug that you solve the question, because it's easy to say, okay, we give you some drug, now you're covered. It's something that what I call, if we start now something, a pathway, it's a therapeutic alliance, and we have to work together. It's sometimes difficult, because it's difficult to stop smoking, it's difficult to lose weight, but we have to do this together. If not, it's not enough to give only some drug.
But would you say to the patient that will not get the drug if you can't promise to smoke? I mean, I think we have to.
The
be
drug
very
is
careful about
but we have to create a kind of transfer that we doing a pathway together. But I will always treat the patient. This is clear.
What about the patient's view on this?
Well, I think many aspects I couldn't agree more. When it comes, as you mentioned, to high blood pressure, I think we can start quite early, teach people, and they can do self-management, and you have the values done at home and in the practice. And so therefore talk to the people, and then you can also explain why pulse checking is important, and why it's important that they look at lifestyle risk factors, and that it's important and what they can do as an opportunity to look after your life. And this is something that has to start again quite early and across the whole lifespan. And then the gain you have is that you will have a life maybe free of stroke or later in life. And this is something which has a little bit to do with the concept of education and health literacy. And there are, of course, a lot of disparities in the population. There are people who know everything and who have every new device to check pulse, etc. But we have to look at the vulnerable people who don't know these things. So I think this is very important for a governmental system, to start early, to have people who could do this. The medical doctors are very important, but there are other people, as you mentioned, who can be trained, and they are willing to do these things. And another aspect, I think, having a healthy environment, to do it in a community, because there are champions in a community. So this is again what I was taught in public health school, but I think this is very, very relevant, because people like to do things for other people in the community, people they know. And then the doctors and pharmacists, they are very important. They have to be involved in the program, of course, and do some kind of quality check. But I think that the role of the doctors is changing. They have to adapt to these things, because people do it on their own. It's a little bit, you will go to the smart technology, and we talked about this later, but people inform themselves about topics, and they build their opinion. And so you have to go into the minds of the people and say, well, this is fine that you do, but you can do better if you do it this and that way.
Right. Yeah, you mentioned the importance of technology. So maybe let's discuss it. I mean, we have smartphones, we have apps, we have wearables, we have all kinds of patches and all these kind of things that these days can be used to collect data on stroke risks, and not just stroke risks, but risks that are, for other diseases as well, for obesity, diabetes, and all kinds of other linked diseases, cardiac diseases as well. They can provide vital information, as we know, on risk factors. And they can really give health professionals also a better idea of at-risk populations. And they can really assist clinical decision-making as well. But how can we really integrate that innovative technology into the clinical setting? Can we educate people to use this kind of technology, both for the management of risk factors and also for the detection of risk factors and monitoring their lifestyle? And to what extent can we introduce low-cost technology and integrate into the clinical setting to make screening faster, easier, cheaper, and more efficient? So maybe let's start with Pfizer the Ems Alliance.
Yeah. So look, there is very widespread uptake of technology, as you just mentioned, Martin. Look, we have quite a lot of technology available to us today, and as you know, there is emerging technologies as well. I kind of think of technologies in several kind of buckets. I mean, we have handheld ECG, for instance. We have the wearable technologies. You mentioned the patch. How we utilize that technology will be very important. For instance, we can use that technology for single point-in-time screening. We can use it intermittently over a 2-week period, or you can use the patches that can do continuous monitoring for maybe a couple of weeks. Of course, we don't know yet what the right technology is to use, and I don't think we've figured out how best to integrate this technology into routine testing in clinical practice. Ideally, you would want this technology to have a high predictive value, to have low risk to the patient, and as you mentioned, at low cost. That's why I think it's important to continue the research, continue to generate data to understand how best to integrate this into routine clinical practice, how to make it viable from a pharmacoeconomic point of view. And that's a lot of the work that the Alliance is doing in the countries that I mentioned previously that'll help us to understand some of those challenges.
I think there is still, though, a problem in as much that if you have a machine that measures the blood pressure automatically, now it's available, patients can use it, it's easy to use and it's very accurate. In terms of handheld devices for rhythm detection, they give a suspicion of an atrial fibrillation, but you still need someone that would confirm it. And so there is a big difference between blood pressure monitoring and rhythm monitors. And that, I think, is an obstacle, because you still have the added cost to have to check it, and it can create, without that, it can create a lot of anxieties to the patient, to the individual, and a lot of extra work to the general practitioner. So a word of caution. I mean, it will get better, it's there to stay, but at the moment, these are the barriers, I think.
Yeah, I think you're right. So most of these devices are detection devices, right? So they usually require confirmation with the 12-lead ECG. I think you raise a very important point about some of the challenges that come with utilization of some of these technologies, right? I kind of think of it as a double-edged sword, right? Yes, the technology is very widespread. It can cause anxiety in people who think, okay, well, I've got a rhythm problem. My watch is telling me I've got a rhythm problem. What do I do? They present to the doctor, presents a clinical challenge. That doctor then has to do an ECG. That's utilization of healthcare resource. So there are health economic challenges. The reality, as you say, is they're here to stay. And some of these technologies have features that are not only heart monitors now, they're rhythm monitors. They can detect atrial fibrillation. So I think how successful we are in ensuring that this interfaces well with the healthcare system, with the clinical infrastructure, will determine how valuable they are for screening.
Yes.
I would like to emphasize that there are at least many methods now to detect atrial fibrillation, not that it needs confirmation, but that we can have real printouts of the ECG showing atrial fibrillation. So I think we are already there. But I also like to state, as you did, that we have to ask the patients who are at risk to do this. And for the moment being, I see a lot of 25-year-old athletes coming to my practice and saying they have an irregular rhythm. That doesn't matter. They are healthy. But how do I get a 75-year-old to start buying one of those watches and printing out? That's the problem, I would say.
So how do we get a 75-year-old? Maybe from a patient perspective, can you give us some insight?
Yeah, I would say from a population perspective and also from a patient perspective, I think we need frameworks, of course. If we're talking of data and privacy and all these aspects. And on the other hand, people will use these devices. And I think that governments should look at the framework together with the experts. There should be the scientific organization be involved, and the producers of these devices should work together, as has been done with the medics and with patients, with the experts, to make the best out of it. And I think medical disciplines have to set the gold standard, but on the other hand, to improve these things. And now we are talking, for instance, another example, but what I'm quite old school with these things, but we will have in 10 years maybe cars without drivers. So it's a little bit an analogy, we have patients without doctors. No, that's not true. But on the other hand,
I think for certain things,
I don't want to say that this would be good, but on the other hand, again, there will be a change of professionals who have to look at these things. And this is something we have to do together. And the government has to set the framework, because this will happen. Everybody in the world, not everybody, many people have a smartphone, they use it. And if they use it, for instance, if a doctor has said to lose weight and use the smart application, I think that's fine. So just one example, and there are studies that this works.
We have produced an app from the point of view of the European Society of Cardiology for the patients and for the doctor, to implement, as an effort to implement the guidelines for atrial fibrillation. But we are going to test it rather than taking for granted that it will be better.
Absolutely.
You know, you'll have to prove it like any other intervention that is actually going to...
That is good medical practice, and this should rule. So, absolutely.
And this is very good, because, as you said, we cannot stop this evolution. And if a scientific society, together with patient, and work together in order to make it scientific, I think this is a really good way of working.
And I mean, I think we know that how important technology is also for data generation. And it's one of the elements we looked at in our study as well, is how countries are generating data and how they're collecting data that feed into the national stroke registries, which are really important to highlight the disease burden, but also at-risk populations, and to really managing stroke risks as well. They're really good tools as well that allow us to kind of follow patients, document their characteristics and experience, and also to understand and track the outcomes of their specific interventions. And the data then can be used to inform the improvements in care and also to inform health policy as well. So how, in your opinion, can governments ensure that more of this kind of clinically relevant data, not just any data, but really clinically relevant data, are collected and support the development of better prevention strategies?
I'm absolutely passionate about this, and if there is someone out there that can do something about this, I think the electronic medical records and the ability to follow up patients through that in the Scandinavian model, it's great. Absolutely the paramount because not only to assess the prevalence of the problem, but also to make the connection between exposure to a risk factor and outcome, say obesity and atrial fibrillation and stroke, say, but also increasingly to test treatment. Because at the moment what we are testing are interventions that have a commercial value. But there are a lot of other questions out there that cannot be addressed in a clinical trial because there is no financial interest of doing so. Say if I want to test whether weight loss versus AF ablation is the best strategy to prevent stroke, I wouldn't find anybody who's funding a study like that. But with the electronic medical record, I could randomize my patients to nationwide to one intervention or another and collect the outcome straight away through the registry that becomes the registry of that nation. Right. And that is really essential.
You mentioned Scandinavian countries.
Yeah.
What is your view on that?
Thank you. I feel honored. But I also like to state that there are some problems with these registries. We can follow populations, we can follow groups, but we also know that we could potentially identify patients who are wrongly treated, who doesn't get the right treatment. But then we have a legal problem. The lawyers come in and say we're not allowed to identify individual patients despite the fact that we know they're getting the wrong treatment. If I was a car producer at Volvo and I know that my brakes would stop working in 25% of the cars, I wouldn't be able to sit with my arms crossed doing nothing. But that is our situation. We are not able to identify these high-risk patients, despite that we know we could if we have the lawyers with us.
Right. So is data privacy, is that the big issue from the patient perspective? If you want to...
No, I wanted just to add, we did something as well from the European Stroke Organization, but about secondary prevention and acute stroke treatment, where we measured the intervention. And then we shared the data with the centers, and what we saw, it is amazing how the performance after this sharing of the data increased, and it was really great. There were centers not doing, for example, thrombectomy not in let's say in 50 minutes, they decreased to 30 minutes, and so on. So if you measure, what you measure, you can change, and I think this is the best way to do it.
Do you agree?
Yes, so coming back maybe to data privacy and the patient view, I think that the patients trust their physicians a lot. They also trust their health insurance company, but they need explanation. And if it goes to data and how data is used to involve patients, to have it really as a democratic process, I think that's the way to solve it. And on the other hand, would be very good to see where the problems in the different systems lie and to combine our thinking and then see if there are, so to say, global solutions for it. And coming to data, coming back to apps, people agree to many things they don't read.
Yeah,
and
that's true.
If there is a framework which is done by experts, by doctors, by lawyers, I think people would agree and they say, yes, of course, if I have a source where I can see my data, where I can share my data with the experts, where I can get advice, that would be very good. And when it comes to registers, I think it would be important. In Germany, we have a few, or we have some registers, but we don't have the data after 3 months or 6 months. Just to see what has been done, what have the patients have done, what treatments they got. I think this is very important, and so therefore we admire the Scandinavians, we too, but I recognize that there are problems in the system too, and I expected that.
We actually had a question come in that might fit in here, because there's a question on which country would you say has the best practices. I mean, you heard about Scandinavia, we heard a bit about Germany. Do you have examples in mind? I mean, our study looked at 20 countries and very diverse results, but I'd just like to throw it out there. Do you have like best practice examples? Which countries are really doing well?
On prevention. So I think you should. The UK model is quite good on this.
Yeah, I mean, it is a little bit of a contentious question, because the moment you say that, like, I would say that there are countries who have a structure in place, and the structure normally involve a strong, motivated, incentivized general practitioner group. And so the primary prevention is done in general practice. And so you need to have that to start with. No point having 1 million cardiologists if you don't have people in the territory, right? And so I would say that all the countries that have that kind of structure normally would perform better, and there are several in Europe, so I wouldn't want to single them out, but I think that is the common thread.
Okay, sounds good. I mean, unfortunately we're running a bit out of time, but I'd really like to ask each of you to also have kind of your view, because in our study we concluded that there are lots of like pockets of great, approaches in Scandinavia, in Germany, in the UK, but there isn't really an integrated, approach that's kind of coherent, that both integrates the population-based approach with the clinical approaches that kind of work together to have like proper early detection and also to identify risks properly. So the challenge really for countries is to support intervention in a coordinated way, in a more coherent manner. But how can we do this? How can stroke prevention really be addressed in this more coherent, integrated way? So I'd like to ask each of you, by way of kind of concluding remarks, to give your views on how this integrated approach can be established.
Sure. Started with me?
Yes.
Okay. Look, I think it's about partnership and collaboration. I mean, we know that 80% of strokes can be prevented. I think for the most part, most countries have a reasonably good policy in place, and we've got very good guidelines, scientifically informed on clinical data. I think our challenge is action around implementation. I think you mentioned that as well. And I think the key is good partnership, good collaboration. And if we can get this right, I really feel we can achieve what I call is a triple win. It's a win for the clinicians because it enables us to identify those patients, detect the risk factors, and then put in place the right measures to manage those risk factors to benefit the patients. A win for the healthcare system, because if we can get this right and we can integrate a economically feasible screening system, that's a good outcome for the whole healthcare system. And finally, and most importantly, it's a win for the patients, right? By early detection, early diagnosis, through the appropriate referral pathways, managing their risk factors, we can prevent, hopefully, many of these strokes.
Great. And Valeria?
Yes, I unfortunately see the patient when the catastrophe stroke is when the catastrophe occurred. So, and I look at the clinical chart and I said, oh, this could have been done, and this could have been done, and could have been done. So we survey, as European organization, we surveyed the whole Europe in order to understand what happened. We planned an action plan on how to treat stroke now until 2030. But I want to reinforce the message of collaboration. We don't need to reinvent the wheel because we have already wonderful models around Europe. We have a wonderful acute stroke model, for example, in Austria, excellent model in stroke prevention in UK. So we have to look the best models for every country and then try to find, because Europe is quite culturally different, a model that can be adapted for our Europe, which is quite different in every part. But I think the collaboration is the key point.
Great, thank you.
Yeah, it's a little bit of a reiteration that collaboration and partnering is very good, but I would like to give some examples. For instance, there are a lot of measures like the government can do. If you think of taxation of tobacco. Yeah. And I think that the money should be used for a better health system and not in other ways. Yeah. This is something, or for alcohol or other things, or also if it comes to beverages with high glucose. So we have these models. We don't have to reinvent the wheel. These have to be integrated in a framework, and there has to be, I think, some kind of national or global strategy about it. And so therefore, many people from different areas have to work together, again, in the community, of course, but then you also have targets, like the WHO has targets, and then you have to measure these targets. So the best thinkers, so to say, together with the population, with the patients, should do this. And there are a lot of things we know that work for many, many years. Project North Korea project started with these things. So the knowledge is there. We just have to use it. And I think the governments have to be aware that there is an increase in stroke and that they have to be prepared. And to involve the users, the patients, the doctors, I think that's key.
Yes. Thanks a lot.
Yes, no, I completely agree. I think that effective communication and communication directly to the citizens and involving the government, which normally comes from involving the citizens more than from the point of view of talking as a doctors to the government. It's very important and will be increasingly important with the change of the generations, and also breaking silence. The cardiologists, the neurologists need to work together with the primary care physician, with nursing, with the patients. So that, I think, will make a difference.
Yeah. Thanks.
Personally, I don't use social media, but I realize that that's where people get their information today. And besides, they're also very interested to hear what famous persons think. And I think if we could, in some way, combine those two things and use that for information, I think it would be very successful, because this is the way it is today.
Great. Thank you very much, everyone. This was such an insightful panel, and I hope you have also gained some great insights from this. Thank you very much for participating, and you can continue to send your questions. And we'll also send each of you a copy of the report that we launched at the Economist Intelligence Unit on stroke prevention. And I'd just like to highlight again that there will be a couple of important awareness days coming up. So the World Thrombosis Day will be on Friday, October the 13th. And then the World Stroke Day will be on Sunday, October the 29th. So there will be lots of activities around the world to highlight how important stroke prevention is. So I'd like to thank again the panel for your participation and also for viewing the webinar. And the debate continues, of course. Thank you very much.